Hello and welcome. I'm Dr. Craig Barnett from the Marshall University School of Medicine, the Division of Cardiology in Huntington, West Virginia. Today I'd like to discuss some of our recent cases using coronary venous retroperfusion in the therapy of evolving acute myocardial infarction and/or unstable angina. This new technique, still in the category of research and available on protocol at our institution, has enabled us to treat patients with these acute ischemic syndromes that we have yet to be able to manage effectively in our community. Before we get on to the cases, I would like to briefly describe our institution and community setting for you. We have a unique blend here in West Virginia of both rural and urban medical centers. Our VA hospital would be classified as a rural hospital in the fact that although it has a division of cardiology and a critical coronary care unit, the nearest catheterization laboratory and heart surgery program is at the Lexington VA Hospital, 2 hours away, even by air ambulance. Our urban center is Cabell Huntington Hospital, and although it is a major trauma center, has no cardiac catheterization facility. The nearest cath lab and surgery program is 10 minutes away by ambulance. The setting here enables us to try this new procedure in patients with unstable angina and evolving myocardial infarction. Before we get on to the case, I would also like to review for you the technology of retroperfusion. Retroperfusion takes blood from a peripheral artery, in this case, on this diagram, the femoral artery, and through an ECG synchronized pump, propels the blood backward in the coronary vein to the myocardium. The heart of this system is a computerized ECG synced pump to pump only during diastole and to allow normal venous drainage during systole. The catheter is a triple lumen retroperfusion catheter with a very special design at the tip to seek out the coronary sinus, making installation easy. The tubing system allows blood to be withdrawn from the artery and pumped retrograde through the retroperfusion catheter into the patient's coronary veins. This case is the first case of acute myocardial infarction treated with retroperfusion, and is a 66-year-old Caucasian male with a history of hypertension, smoking, and a very positive family history. He presented with clinical signs and symptoms of an inferior posterior myocardial infarction of approximately 2.5 hours duration. His diastolic blood pressure of 140 meant that thrombolytics were contraindicated. Therefore, his initial therapy of intravenous nitroglycerin, intravenous beta blockers, and heparin, and along with chewed aspirin, resulted in some decrease in pain, but no significant change in his ST elevation pattern of myocardial infarction. Retroperfusion was carried out from the left subclavian vein, withdrawing blood from the left femoral artery. Of note, a solo operator accomplished the entire case, and the catheter was placed well past the posterior vein in the coronary venous anatomy to the coronary sinus and silent zone itself, even though we knew that there was posterior and lateral dyskinesis. The initial retroperfusion results were of total relief of pain and normalization of ST segments at a flow of 250 cc's per minute. The 4-hour wean, and again this is a protocol so that our patients are weaned from the pump at various times, resulted in a return of pain and a mild ST elevation at a reduction of flow to 100 cc's per minute. The final results of retroperfusion were that the patient tolerated a wean from the pump at 12 hours to 0 flow. He had a CPK washout that peaked at 12 hours and was transferred to the Lexington VA Hospital for coronary angiography, which showed a proximal eccentric 80% stenosis in a large codominant circumflex artery. His technically dominant but small right coronary artery had a proximal stenosis and had a mild stenosis in the proximal posterior descending artery. Unbeknownst and unannounced by any clinical or angiographic parameter, the patient suffered acute reocclusion of the circumflex lesion while on the ward in Lexington. His ST elevation pattern was identical to that of admission. He underwent successful emergency PTCA at that time and is now asymptomatic at 1 month follow-up. We would like to review the ST segments of this patient. Our ST segments on our protocol are monitored by the Matora monitor, which is a 12-lead ST map that is plotted over time. This is a normal patient. This is an abnormal patient of an anterior myocardial infarction, untreated. Notice the magnitude of ST change and the fluctuation of ST segments over time. This is our patient with inferior and lateral ST elevation and anterior ST depression, consistent with a true inferior and true posterior myocardial infarction that resolved with pumping to a normal ST pattern. His ST elevation is noted here and here with ST depression on the 4-hour wean. Of note across the time scale is the 12-hour wean without ST elevation and the stabilization of the EKG towards the end of the procedure. The echo data can be seen in that he began with dyskinesis as analyzed by a centerline method and progressed to good systolic wall motion on maximum retroperfusion. Prior to the first wean, he continued with good systolic function, but with pain and ST change had a significant reduction in systolic wall motion. He had a return of the wall motion on the maximum pumping after the wean, and unknown to us at the time, we were not able to analyze this with a computer at the time, he had a decrease in systolic function that was not accompanied by ST change or pain. At 1 month follow-up, he has good wall motion and is asymptomatic. So in summary, we have had the opportunity to treat a patient with an inferior posterior myocardial infarction with coronary venous retroperfusion. I feel that this is a good example of retroperfusion therapy and case management on our current protocol.